2014, life expectancy in the United States declined for the first time in 30 years. Life expectancy is one of the two key indicators of how healthy we are as a population. We know from life expectancy and infant mortality we can measure the health of any population. Was this something we should have really been concerned about, a one-year drop in life expectancy, even if it had only been in the 30-year period? Probably not. Most of you probably didn't even notice it or even have any concern about it. But guess what? It's not unprecedented. And it happened again in 2015, 2016, 2017, and in 2018, interestingly enough, our life expectancy increased a little. If you saw the news a couple of weeks ago, that's when the data came out. Primarily, it increased because we started doing something about opioid overdoses. But how far back do we have to go to see a trend like this? You have to go all the way back to 1914 through 1918. 1914 through 1918, we had two things occurring in the world. The Spanish flu pandemic, which was killing 50 million people, and World War I, which killed 40 million people. Nothing like that was going on from 2014 to 2018. So, what determines life expectancy? The young man in the center of this slide is Hippocrates, the father of medicine. A long, long time ago, in 55 BC, he wrote an essay entitled Airs, Waters, and Places, in which he said, the air we breathe, the water we drink, and the places we live determine how long we live as a people. Probably you're chuckling going, well, that's a long time ago. 2,000 years? Well, not a lot's changed, interestingly enough. See the slide of LA? You'll notice that that's a recent slide. Air pollution is still a problem. We have a couple of 100,000 deaths each year in the United States that are attributable to air pollution causes. The Navajo village depicted here, its residents drive an hour to get water. We have over 2 million Americans without access to running water. Probably the most important part of that triangle is the bottom part, and that is the chart that shows life expectancy in the United States. You're sitting here in Monterey, California, and if you look at that map real quickly, you'll notice that's one of the golden states. People live in their golden years much longer here than almost anywhere else in the United States. If you look at those red shaded areas, which is where I come from, people live a lot less. Now, what happens if you drill down a little further? Drill down into the difference between the races. Never in the history of the United States have blacks had equal to or greater life expectancy than whites. Never. Why is that? It's a product of racism, slavery, and the institutions we've created. Just think about this for a minute. 93% of our physicians are white. So we have some real problems in disparities and equity in healthcare. But let's drill a little further into this map. And let's look at infant mortality. I talked about life expectancy. Infant mortality is the other measure of how healthy we are as a population. Whereas the United States ranks 34th in life expectancy behind countries like Lebanon and Slovenia, in infant mortality we rank 29th in the world. If you look at some of these red states, non-white infant mortality there would be approximately what you would see in Cambodia and Bangladesh. This is in your country that you live in. Now, I'm sure some of you are sitting there going, well, this is a socioeconomic problem he's talking about. It's got really nothing to do with race, it's socioeconomic. Well, yes, it does have something to do with socioeconomics, but not so much. For example, if you take a black woman with an MD or a PhD, she has 3 times greater risk of an infant mortality than a white woman with a high school degree. So it's not a socioeconomic problem. It's an equity problem. What are the underlying causes? How did we get here in this country? We have a dual healthcare system. All those nations that rank above us in life expectancy and infant mortality have national healthcare systems. Healthcare is a right, not a privilege there. And their numbers indicate that. And the numbers are pretty much the same every year. We're always going to stay down in we usually rank in the 20s and the 30s and always have as a healthcare system. But we have what is called a public system and a private system here in our country. Almost all of you sitting here are in the private system. Your employer either provides your health insurance or heavily subsidizes it. You have access to care, you have quality care, and most importantly, you have continuity of care. If you get a diagnosis, you're treated throughout that entire episode very well and taken care of. Let's flip over to the public side of the system. Public side are those people on Medicaid or those people who have no ability to pay. They get their care through emergency departments and hospitals. They get their care at urgent care centers and through community-free clinics. Guess what doesn't happen? Continuity of care. When you get episodic care, it is not continuous, which means the quality of that care drops. So, is this a Homeland Security issue? Well, let's look at Dallas, Texas, the Ebola case, which you all remember. The young man presented at a affluent private hospital in Dallas, Texas, with a temperature of 103, coming from a country where Ebola was endemic. He was sent home. He infected other people, and we dodged a huge bullet in that case. Right now, we're in the middle of a coronavirus. You're going to see some of the same things happen again, and a lot of it has to do with the fact that we have this dual healthcare system where a lot of people do not get care readily, and it's not easily accessible to them. Don't want to talk about problems and say there are all the problems that are not solved without talking about some solutions. It's important to remember that as we deal with complex problems like this, they have solutions, but they also have underlying causes. What we have going on in our country now in health equity is called America's cancer. It's become the new term. It's also being called diseases of despair. I'm going to pick out 4 of these and talk about them, primarily because they affect about 1/3 of our population. About 80 million people just in these 4 areas. And the areas I'm going to talk about are what are called the social determinants of health. That's been the new key word that's being used by folks all over who deal with healthcare issues. In each of these, I will address the problem, but I'm also going to challenge you with some of the opportunities you have to make a difference, which I think is important. I'm going to start out with violence. It's one of those issues. Last year in our country, we had more mass shootings than we had days. We have homicide rates in some of our cities that are at unprecedented levels. What are being done about these issues? Well, you'll see this flowing throughout everything I'm saying, but one of the things that we have is a failing mental health system. So mental health has been called upon continuously to improve its services to address some of these problems. What you'll see in terms of solutions that are being incorporated in our country are such things like they're happening in Wisconsin right now, where they're developing what they call mental health friendly communities. So when you drive into one of these cities, you see a sign on the outskirts saying a mental health friendly community. Man, what does that say to you? Pretty good place to live. They're taking care of their folks. Education is also being brought into this violence issue very much. We know that we can look at the number of children in the 3rd grade who don't read at 3rd grade reading level and predict the exact number of prison cells we'll need 10 years later. That's a huge challenge that New York City has recognized. their head of schools, has made that one of his major challenges to address literacy levels in the schools there. What's there for you to do? There's a lot of opportunities. The two men depicted in this picture took it upon themselves to realize that we don't have an accurate database of school shootings. They developed that. It was nationally recognized and acclaimed. It's being used for research work all over our country. You have that opportunity as well to do the same thing. Look at issues like this that have not been solved. I travel frequently to Spain each year, and I always notice the schools there all have a wall around them with a gate under video surveillance. Don't remember the last time I saw a school shooting in Spain. Probably never been one. But think about this for a moment. Wouldn't it be interesting for a person to look at a cost-benefit analysis of building a wall between the United States and Mexico versus a wall around all of our schools? And wouldn't we love to wake up every day and never see another Columbine or another situation that's happened in too many of our schools? Again, two young men who took this on as a challenge. Homelessness. Second one. Homelessness affects between 500 to 600,000 people in our country every day. How do we know this? We actually count them every January. The numbers never change much. What does that tell us? We're not doing much. Finland took this on as a major challenge and is now receiving worldwide acclaim for it because they reduced their homeless population by 40%. What did they do? They built smart shelters with mental health services, social services, and health services incorporated. What can you do? You can advocate for homeless shelters in your community, volunteer in them, help out where needed. It's a critical issue that needs to be addressed. Let's move on to food scarcity. We have throughout our country what are called food deserts. People do not have the ability to access good foods, healthy foods, other than snack foods in many areas. Magic Johnson took it upon himself when he quit playing basketball to make this one of his major causes. And one of his significant accomplishments was to get the first grocery store in Harlem in over 40 years. Think how big Harlem is without a grocery store. A very significant piece of work on his part. In all of our communities throughout the nation, we're building food banks, food pantries, blessing boxes. All those things are opportunities for you as well to address the food problem, which affects about 10 million households and about 22 million Americans who don't have enough food every day in this country. Finally, let's move to access to health care and mental health services. About 44 million people in the United States do not have money to pay for health care. They're not covered by any program. What's the impact? We have an exploding obesity rate. Over 50% of our population are obese now. We have an exploding diabetes type 2 rate. And we also have a growing and increasing number of teenage suicides. All of those relate to our healthcare system and our mental health system. What are we doing about that? 35 states in the United States have expanded Medicaid. That means 15 haven't. It's a very political issue in our country. I live in one of those 15 states that have not expanded Medicaid. I myself am running for state legislature solely for that reason. Expanding Medicaid is important to increasing access to health care, something that we do so badly at, something that we can't do and continue to do and not address those 44 million people who don't get adequate health care. Finally, what are the challenges for you? If you look at these numbers that I just ran through between all of these problems, the violence problem affects roughly 11 to 12 million people directly in our country each year. The food scarcity problem affects about 22 million each year. Then when you move on to healthcare, it's 44 million. Then add in the homeless problem. So just in those 4 areas, out of about 15 social determinants of health, you have about 60 to 80 million people, depending on how you count them. These are extraordinary challenges that we face. If we are to solve America's cancer, as it's being called, and deal with these diseases of despair, we have to start taking initiative and taking action. These are, in my mind, all threats to our homeland security. We must accept these challenges and we must meet them. Without them, America's cancer is going to continue to grow. And as that grows, it will affect each one of us. Thank you. First thing to remember about private insurance is that the more times you use the system, the more money they get. So it's to their benefit for you to be sick and you to be unhealthy. But if you look at the entire system in general, we have spent a good 30 to 40 years dismantling our public health and mental health systems. Back in the Reagan administration, it was decided that the best place for mentally ill people to be was in their home county, in their home area. So we deinstitutionalized mental health and pushed everybody into the streets. I think anybody walking up and down the streets of any major city knows how well that's working. Not very well. And at the same time, we've done very little to fix that problem. On the other side, the public health system, which I just finished working in for 40 years, saw the same thing, a continuing degradation of the funding and support it receives. This coronavirus is a serious issue. It requires a centralized system, which is what most countries have to deal with it. I was reading the Times of London a couple of nights ago, and there was a big article that the National Health Service there is getting ready, putting everything plans in place for 50% of its population to be affected. Have you read anything like that in the U.S.? No. That's because we don't have a unified way of approaching healthcare in this country. As a local health official, no one could tell me what to do, nor could ask me for help, nor would I have to provide any of my 250 employees to do anything. That's an interesting system for handling problems in a country. And that's what we have pretty much throughout our nation. The old saying is, if you've seen one health department, you've seen one health department. It's really true. And it's a scary proposition facing some of the problems. Well, I would agree with you. We can't solve everyone's problem. Interestingly enough, when you drill down into the folks that are in homeless shelters, and folks that are having a lot of these issues, the folks that are hungry, what you find is that the limitations, either physically or otherwise, economically, have put them in the situations they're in. If you take a person who is homeless and you give them absolutely nothing but a shelter, and that's all you give them, all you're going to do is keep running them through shelters. And that's what Finland learned. And people are rushing from all over the world to study what they've done there. But the comorbidity there is always going to be mental health issues, in most cases, or financial issues. Much less, but mostly mental health issues. So we have to address that. If you look at food scarcity, I mean, a lot of folks, and I would encourage you to read a book called Nickel and Dimed in America. It's a great book. But it points out that people will joke and say, okay, so-and-so ate a bag of hot dog rolls for lunch. That's what they did with their money for lunch. Well, guess why they did that? Think about a bag of hot dog rolls for $1.50. What are you going to spend for fruit, vegetables, and things? And you can get full on a 6-pack of hot dog rolls. But you can't get full on one thing of raspberries for $4.95 in Whole Foods. It doesn't happen. So yes and no. It is personal responsibility, but there are other situations that people have to be helped and some solutions provided. Well, I've always been one of those people that felt like we do a bad job of recruiting physicians to begin with. And primarily they end up in the most populated areas. And we don't seem to incentivize them to work in rural areas. We have the rural incentive programs. But I live in a county of right at 250,000 people next to Charlotte, North Carolina, and we're considered a rural healthcare area. Go figure that. So I see counties like in North Carolina, Bertie County in the eastern part of the state is a rural county, not a county that I work in. I think we need to change the structure and the way that we bring physicians into the institutions they train in and incentivize them to stay there for a while in those areas, but make the education much less expensive. A lot of medical schools have gone to making it a free education for the physicians. So that's one of the ways that we can increase it and make it more available, especially to minorities, which we don't do a good job of. I can't imagine, you look at this room and you're a pretty good picture of 93% of your physicians are white, just like this room. And think about if it was reversed and you were going to the doctor. One of the things that happened with the opioid overdose is guess who didn't get the painkillers? The black population. Because the white doctors weren't prescribing for their pain. But they were giving it to us because we were white. So, yeah, we've got a lot of changes, and we need to especially bring more minority physicians into our Good points. Interestingly enough, if you look at life expectancy in Sweden and the Scandinavian countries versus England versus the United States, you'll see the same differences for the last 60 years. England's always above us, Scandinavian countries above them. Hasn't changed much in over 60 years. Is that attributable to a national healthcare system? Not so sure I can say that, but the evidence is there. And if you look at those charts, look at them every year, all the countries above us have a national healthcare system. I don't think we'll ever see that here because of the politics of it. But I think we need to do something if we're going to address the health equity issue in the United States is a travesty and needs to be addressed. Excellent question. We tried and still have a food recovery program, but interestingly enough, between health and agriculture, we got crosshairs because our Department of Agriculture said, those cartons of milk in the schools that aren't being drank each day, those apples that aren't being touched, can't be reused. They have to go in the trash. Made no sense to us, but that was the Department of Agriculture ruling. So we lost tons of food that we're recycling every day. Good food, healthy food. What I see in a lot of the operations, food pantries you're talking about, cakes, pies, things that are just high starch, high fat, high carbohydrate foods. One of the things we did, and the picture in the slide shows it, is we've been working a lot on corner stores. Corner stores are usually in food desert areas. And one of the things we want to do is see if we could get people to start stocking fruits and vegetables and continuously use them. And this is a store that we painted, fruits and vegetables. Used to be a 7-Eleven in the old days. And inside, when you walk in the store, there are footprints leading you to all the healthy items. 4 years later, the owner is still stocking them because he says he's making money off of them. And a lot of that was education, going in and working with that owner because you can't store certain fruits with each other. They make each other rot. So getting them to understand how you display, how you store items was important. But you're right, it is a huge problem. And it's a significant, getting the right food recycled to the right people. Los Angeles has an excellent program doing that. And that's one of the models we use to try to do ours. But they're not widespread, and again, it gets into laws in each state and problems with trying to use food that should be, in my mind, easily reusable. It does cost money, but those things are working. In our community, when someone has an opioid overdose, we led the state for 6 months in opioid deaths, overdoses. And our EMS put this in place. They actually go and make a visit after the fact, 1, 2, or 3 to that home. When someone is diabetic, they do the same thing. So we identify certain chronic diseases, and these programs work. I've always been struck by when I'm in my primary care physician's offices, when I look around the room sitting around me, and I'm older now, so I see a lot of folks with diabetes, and I always notice that people missing limbs sitting in the wheelchairs around me are always black, not getting the proper care that they should be getting. And how difficult it is to access that system to begin with. I was there that day. The gentleman talked about getting into the national healthcare system in England. I woke up one day and couldn't move my neck. It lasted for 3 weeks. It finally got a little better, but I called immediately for a doctor's appointment. 3.5 months to see my PCP. When I got there and finally got it diagnosed, it was severe spinal cervical arthritis that was going to be degenerative. Probably not a lot could have been done, but I waited 3.5 months. And I think about the problems you're talking about, where people are just seeing that episodic person who comes out, takes them to the hospital, brings them back home, and then that's the end of the story, and they don't get any further care. And hence the reason why we have these so-called diseases of despair in our country that are continuing to get worse.